Hi friends, how are you? Welcome to my YouTube channel D&D Pathshala. In this video, we will see regarding the drug-induced blood disorders part 2. Means we will see regarding more drug-induced blood disorder types. So, the second type is drug-induced agranulocytosis. So, what is this drug-induced agranulocytosis means? It is defined as the reduction in the number of the mature myeloid cells in the blood. Means here the mature myeloid cells will be like the granulocytes and the immature type of granulocytes. That is, these immature granulocytes are also called as bands. So these are in a range of 2 a total count of 500 cells per cube or less. Means this condition will be the reduction of the matured myeloid cells in the blood. That is, it may be the granulocytes and the bands. If they are less than or equal to 500 cells per cube, then this will be represented as drug-induced agranulocytosis condition. Now coming to its occurrence means, its occurrence will be about mostly in the females and in the elderly also. In the elderly greater than 60 years of age. And the estimated type of annual incidence is 1.1 to 12 cases. Means in a million population, 1.1 to 12 cases per million population is seen as the estimated type of annual incidence. Now coming to its overall mortality rate, in the agranulocytosis, it is estimated to be as a 3.5 to 16%. And this rate will be higher among the elders and also in the patients with the renal failure and bacteremia condition. Means the presence of the bacteria in the blood and also the shock at the time of the diagnosis. So this is the overall type of mortality rate in this type of conditions, and its rate means its increased rate will be present in these particular patients. Now coming to approximately 5 to 6%, these are actually resulted as a fatal type of outcomes in most of the cases, and mostly it was thought that the drugs affect only the mature type of granulocytes, causing the maturation arrest. So the immature condition will be because of such type condition, means the drugs will affect the mature granulocytes, which will be causing the maturation arrest. And in most of the recent type of studies, they have described that they may be mostly caused by either the direct type of toxic effect or an antibody mediated effect on the bone marrow, neutrophils, or on the stem cells. So this is the information regarding the drug-induced agranulocytosis. Now coming to the drugs that which are associated with the agranulocytosis. As I have said in the previous video regarding the drugs that which are associated with aplastic anemia, they are of observational study evidence and they are of again case report evidence also. So coming to the observational study evidence, the drugs are like carbamazepine, carbimazole, and clomipramine, digoxin, dipyridamole, and also imipenem, mirtazapine, phenobarbital, valproic acid, ticlopidine, so ticlopidine, sulfonylureas, valproic acid, and zidovudine. So these are some of the observational study evidence cases. Whereas when coming to the case report evidence are acetaminophen, acetazolamide, ampicillin, captopril, and also NSAIDs, nafcillin, olanzapine, penicillamine, penicillin G, pentagocin, phenytoin, clindamycin, dapsone, and also griseofulvin, hydroxychloroquine, tolbutamide, streptomycin. So these are some of the drugs, and NSAIDs are also mostly reporting the such type of case report evidence by causing, that is, the drug-induced agranulocytosis condition is also reported by a case report evidence regarding the NSAIDs. So these are the drugs that which are associated. Now coming to the other type of reasons like the pathophysiology. So coming to the pathophysiology, it will be mostly occurring by the 4 types of immune type of mediated mechanisms, like by hapten mechanism, innocent bystander phenomenon, and by protein carrier mechanism, and by the production of autoantibodies to spoiled or spoilt membrane. So these are the mechanisms. So we will see in them in detail. Now coming to the hapten mechanism. So the hapten means if a drug or its metabolite adsorbs on the surface, means if it binds to the stick to the surface of the neutrophils, then a drug membrane complex will be formed. So this drug membrane complex will be acting as a hapten. So this hapten will stimulate the antibody production, and then the antibodies will be binding to the complex. So by the binding of the antibodies to the complex and by this stimulation of the antibody production, it will be leading to the destruction of the neutrophils and the WBC via complement and phagocytic system. So by this destruction of the neutrophils and the other differentiable type of conditions, differentiable type of conditions like WBC via complement and phagocyte type of systems. So the most important type of our large drugs that are like large doses or repeated doses of penicillin and its derivatives, like its derivatives will be causing such type of destruction of the WBCs and neutrophils also. Now coming here, if the low dose of penicillin can also be taken after neutropenia can be resolved. So after neutropenia is resolved, low dose of penicillin can be taken. And this is the hapten mechanism. Now coming to the innocent bystander phenomenon. In this mechanism, actually the drug will be bind or combined with the drug specific antibody, and this will be forming a complex. So this complex is non-specifically binding or adsorbed to neutrophil membrane. So in this innocent bystander phenomenon, binding will be occurred to the antibody, then complex formation, then this complex will be non-specifically binding or adsorbed to the neutrophil membrane. So it will be resulting in the complement type of activation. It will induce the antibody type of production, and activated complement and phagocyte system will lead to the destruction of neutrophils and cell systems also. So mostly it is caused by the drug like quinidine drug. So this is the innocent bystander phenomenon. Now coming to the third, that is the protein carrier mechanism. The drug will be binding to the protein carrier. So by the binding of the protein carrier to the drug, means the drug if it is bind to the protein carrier, then it will attach to the cell membrane. So if the cell membrane is attached, then the formation means complex formation. So by the formation of the complex, it will be adsorbed to the neutrophil surface. So as this is binding and it is attaching and it is forming a complex and then it is adsorbing to the neutrophil surface, it will induce or it will give rise to this antibody production. So by this giving rise to this antibody type of production also, then it will be binding to the drug protein carrier. So as this is binding to the drug protein carrier membrane complex, so by such type of binding, then it will activate the complement and destruction of the neutrophils. Then the other types of mechanism, like the cells will be get cleared by the phagocytic system. So this is the process that which is undergoing in the protein carrier mechanism. First it will bind, then it will attach to cell membrane, formation of complex, then adsorbing to the neutrophil surface, and then inducing or giving rise to antibody production, then binding to the drug protein carrier membrane, and after complex and activating these complement and destructions, so then the destructions, and then the cells will be cleared away. This is the third mechanism. Now coming to the fourth mechanism, means the production of autoantibodies. It will be getting by either spoiled or spoilt membrane, means autoantibodies will be produced to a spoiled or spoilt membrane. So the drug that which actually alters this neutrophil structure, so by the alteration the neutrophil structured membrane, it will be leading to the autoantibodies. So that is autoantibodies means automatic type of formed autoantibodies. So as these are formed, then they will be binding to the neutrophils. So after their binding to the neutrophils, then they will lead to the destruction of the neutrophils. So this destruction of neutrophils is carried out by the phagocytic system. So now we can all know that the phagocytic system is having a very important role in our body. And after that, some of the drugs like in higher concentrations like beta-lactam antibiotics, valproic acid, carbamazepine may also lead to the toxicity of pluripotent or bipotent. Like mostly beta-lactam antibiotics and valproic acid, if they are given in high concentrations, then they may lead to the toxicity of the pluripotent, means to the main stem cell. That is either it will lead to the having the ability, means having the ability to produce two types of cells. So what is this bipotent meaning is having ability to produce two types of stem cells. So these are the some of the drugs that may cause toxicity, and other types of drugs like propylthiouracil, methimazole, ticlopidine, phenothiazine, and also other drugs like chlorpromazine. Now coming to the chlorpromazine, it will be mostly affecting on the GI phase, that is gastrointestinal phase. So GI phase is the gastrointestinal phase, but here it will be affecting the G1 phase. In the cell cycle there will be G0 phase, G1 phase. So this G1 phase will be coming under the cell cycle. The GI means it is the gastrointestinal. So the gastrointestinal is not having any role in here as we are discussing regarding the hematological. So here the chlorpromazine will be affecting on the G1 phase. This G1 phase is actually needed for DNA synthesis, and G0 phase is the resting phase, and such other drugs like clozapine. So these are the pathophysiologies regarding the drug-induced agranulocytosis. So this is the mechanism, so these are the hapten mechanisms. Here the drug is binding to the antibody. So these plus and minus particles are antibodies. So this drug is binding to the membrane of blood cell and antibodies are formed like hapten. So this is the hapten type. Then the antibodies will attach to the complex and cell toxicity will occur. So this is hapten mechanism, and this is the innocent bystander mechanism. So this is the drug and this is the complex formation, and these are the antibodies. So as the drug is attached with the complex and these are stick to the cell, so it is forming a complex, and complex will be non-specifically binding to cell membrane. Complement will activate and cell is lysed, means the cell engulfation process will get started. So these are the two kinds of mechanisms. And this is the protein carrier mechanism, that is the third step. So these are the representations, means the dot is represented as drug and this image is represented as plasma protein, and this is antibody and this is the cell membrane. Now the drug is binding with the plasma protein. So this plasma protein and this is the, so by this plasma protein is attached with the cell membrane. This plasma protein and the drug are attached. So as this is the antibody formation, so by the antibody formation, antibody will get attacked, means this antibody attacks and it will attach to this particular type of complex, that is drug and plasma protein cell membrane complex. Antibody attaches, and antibody attaches means complement activation, then in final cell toxicity. So this is the protein carrier type of mechanism. Now coming to the signs and symptoms. The signs and symptoms will be appearing within days to week, means after the initiation of such type of causative drug. Like the middle type of exposure, it will be depending upon the development of this granulocytosis condition. It will be ranging for about 19 to 60 days, means within 1 month to about 2 months. So 19 days is also not a completely 1 month, but if we take it as a 1 month condition, so within 1 to 2 months the symptoms will be getting exposed and the middle exposure will also develop. Now coming to the symptoms like sore throat, fever, malaise, weakness, chills, and increased probability of getting infection, such type of conditions. So these are some of the symptoms. Now coming to the treatment. It can be resolved by giving the supportive care and also by the management of the infection. So first and foremost step is removing the suspected or the offending, or we can also say as the problem causing drug. So first of all we should remove. And the symptomatic treatment, like to reduce the infection, antimicrobial should be given, and the antimicrobials or antibiotics should be given, and highly careful hygiene conditions should be maintained, and the neutrophil recovery range will be between 4 to 24 days, means by giving such type of antimicrobials the infection rate will decrease and the neutrophil recovery will be also seen between 4 to 24 days, means within 1 month. And some of the drugs like sargramotism, that is GM-CSF, and filgrastim, GCSF. So these are actually some of the drugs that which are to be shown to shorten the duration of neutropenia, antibiotic use, and hospital stay. So this sargramotism and filgrastim, GCSF, it is given in a dose of 300 mcg per day, that too in the form of subcutaneous injections. Sometimes it is given in lower than standard doses, means I have said in this previous point 300 mcg. Sometimes it is given in the dose of 100 to 200 mcg per day also. So recommended for such type of patients like with a neutrophil nadir, means if the neutrophil count is less than 100 cells, then these are being recommended for such type of patients, and those who are having higher rate of infections and fatal type of means death type of complications, like when compared with those who are having high neutrophil count, for such type of patients these are recommended. Now coming to the drug induced hemolytic anemia. So drug induced hemolytic anemia means in normal actually the RBCs survive for about 4 months, means 30 days, 30 days, 30 days, 30 days, means 4 months. So before they are actually removed by the phagocytic cells of the spleen and liver. But here premature means which are not matured completely. So in the premature stage only the RBCs will get destructed. So their process will be faster than the bone marrow can replace. So it can be also called as hemolytic crisis also. Now coming here, this will be occurring because of either defective RBCs or abnormal changes in the intravascular, means within the blood vessels or the vascular type of systematic environment. So because of such type of conditions, these may occur. And anemia also occurs when this RBC rate of destruction exceed their rate of production, means if the production rate is decreased when compared with the destruction range, anemia will also increase, means production range is decreased, destruction range is increased. So depending upon the destruction range, the anemia will also occur. And the drugs that can also promote both processes, they are actually divided into two types, and they are immune. So divided to two types, they are immune and also metabolic. So immune type means, so this hemolytic anemia is also actually divided into two types. One is immune type and metabolic type. So immune type means it may actually operate, means operate type of process that may lead to the immune mediated agranulocytosis, or it can also suppress the regulator cells that may lead to the production of the autoantibodies. So this is the immune type, means in one single point the operating process will be leading to the immune type of mediated agranulocytosis. By such type of conditions, it may suppress the regulator cells or it may also produce autoantibodies. When coming to the metabolic or oxidative, means it will be involving the induction of the hemolysis, means the hemolysis process will be initiated by the metabolic abnormalities in RBCs. So these are the drug-induced hemolytic anemia conditions. So this is the hemolytic anemia. As we can see in the normal picture, the white blood cells, platelets and RBCs are abundant, means they are sufficiently present. But whereas when coming to the hemolytic anemia, here the RBCs will be present but with defected membranes, means half cut, not fully formed and immature. And the cell fragments, means the cell fragments will be also seen as they are immature, and the red blood cells will be breaking very quickly. So this is the hemolytic anemia condition. Now here in this drug induced immune hemolytic anemia. So here this is the drug induced immune hemolytic anemia, means here mostly the immunoglobulins like IgG, IgM. So these will be mostly binding to the antigens on the surfaces of RBCs. So like here IgG and IgM will be binding to the antigens onto the surfaces of RBCs. Then they will initiate or start their destruction, means first of all IgG and IgM. Then they will bind to antigens on the surface of RBCs. Then they will start their action by destructing through the complement and the mononuclear phagocytic systems also. So this is the destruction type of process. And depending upon the antigenic, means the stimulation process by the antigens, this immune hemolytic anemia, it is either classified as autoimmune, alloimmune or drug induced. So drug induced autoantibodies or antibodies, it may recognize the host intrinsic, means within the RBCs antigens or the RBCs that which are bound to drug. So this drug induced antibodies, and if the antibodies react against the RBC bound drug, then the drug must be present to induce hemolysis, means the drug is such type of case, means it should be initiating such type of hemolytic conditions. So these are the drug induced immune hemolytic anemia method. Now coming here, the drugs that which are involved in the immune hemolytic anemia are like phenobarbital, phenytoin, ribavirin, and so these are the observational. When coming to the case report evidence, procainamide, probenecid, beta-lactam antibiotics, cephalosporin, ciprofloxacin, streptomycin, sulbactam, and NSAIDs. So, have you all noticed regarding that in any drug-induced immune hemolytic anemia, the NSAIDs are mostly involved. So, that's why the NSAIDs are very dangerous. So, the NSAIDs should be taken on purposely, means they can be taken, but if you have a purpose to use that NSAID, then only these NSAIDs should be used. Otherwise, unnecessarily the NSAID shouldn't be used. So coming to the pathophysiology, in same mechanisms like drug-induced granulocytosis, like Hampton mechanism, innocent bystander phenomenon. So, and also drug-induced autoimmune hemolytic anemia, and other mechanism like non-immune protein adsorption. So these are the pathophysiologic symptoms. So pathophysiology regarding the first pathophysiology regarding drug-induced immune-mediated hemolytic anemia is Hampton mechanism. That is, adsorption of the drug will occur to RBC membrane to form Hampton. Then this antibody will attach to drug. So I will be explaining you in a flowchart type. So adsorption of the drug will occur to the RBC membrane. Then this process is occurring to form Hampton. Then this antibody will attach to the drug. So by the attachment, this attachment also occurs without any kind of direct interaction with the erythrocyte. So extravascular anemia means outside the cell. So outside the cell environment, the anemia that which follows, this is mostly caused by the immunoglobulin G. And this here, the complement is actually not activated. So this anemia condition may actually develop over 7 to 10 days. And it can also get reversed within a couple of weeks, as the offending or the problem causing drug, if it is discontinued, then the anemia will usually reverse. Most of the primary causative drugs are like penicillins, cephalosporin, that too in high doses, and the other drugs like minocycline, stolbutamide, and streptomycin, semisynthetic penicillins. And here again, the streptomycin will be mostly associated with the activation of complement system. By such type of reactions, here the Hampton mechanism. And coming to the innocent bystander phenomenon, the drugs actually which induce this type of reaction will be binding very weakly to a normal RBCs. So the immune system, as I have said, this is immune mediated. Our own immune system will identify this complex as a foreign or a neoantigen, and it will start initiating the lysis, means it will start the destruction process of the RBCs through the complement system. As soon as the complement is activated, then the complex will get detached and it will move on to other RBCs or other WBCs or platelets. So because of such type of flow affinity, only a small amount of drug is actually needed to cause this reaction. So this is the innocent bystander phenomenon, and mostly here this low affinity of the small amount of only drug is actually required. And coming here, the other type of conditions, like here we can also say if the complement is only to be found, then a test is there, that is direct Coombs test. So if the complement only condition, the direct Coombs test will be positive. And RBCs are one of the essential victims or innocent bystanders of the immunologic reaction. Means in the complete whole process, the RBCs are affecting. So they are the victims, or we can also say as innocent bystanders, means they are in the middle of the process, and because of this type of process they are getting affected. And such type of mechanism is actually associated with the acute intravascular hemolysis. That is, it can be severe, and it can be also sometimes it can cause like renal failure, hemoglobinuria, means the presence of the blood. So because of such type of mechanism, the intravascular hemolysis occurs, and these are some of the severe symptoms. And prototype drugs means the drug that which is actually introduced before initiating or before developing the final or the other type of main drug product, like quinidine, phenacetin, and others like quinine. So such type of drugs, several sulfonamides will be also mostly involved. Now coming to the other pathophysiology, drug-induced autoimmune hemolytic anemia. So drug-induced autoimmune hemolytic anemia means here the drugs will be mostly inducing the true type of autoantibodies to the RBCs. So here the true type of autoantibodies means up to now it is not false, but here it will be inducing true type, means the particular real type of autoantibodies to the RBCs. Means here the different type of process will be occurred. So first of all, if we take in this type, the first drug is like methyl dopa. So as the antibodies can be identified without the presence of problematic drug or its metabolites. So in the cases like patients with this treatment, means less than 1% will be developing experience of the hemolysis, and it can also develop from 4 to 6 months to more than 2 years of the start of this type of therapy. So proper mechanism of this methyl dopa is not known, but there are actually two types of explanations. Like if the methyl dopa or its metabolites will be acting on the immune system and they will impair the immune tolerance. And offending drug may bind to such another mechanism is offending drug may bind to immature RBCs, altering the membrane antigens and inducing autoantibodies. So this is the mechanism that which is involved in drug-induced autoimmune hemolytic anemia. Now coming here to the non-immune protein adsorption. So this is another mechanism. Here it is a newest mechanism also. So in this what will happen means the drug will alter the RBC membrane like the normal plasma proteins, including the immunoglobulin G also. So by the alteration process, the drug will get absorbed to the RBC membrane, means it will bind to that. Then the RBCs that which are coated with this immunoglobulin G, they will be interacting with the macrophages, and thereby they will be also resulting in the hemolysis process, that is the cell destruction. And other drugs that which may also have been reported to cause such type of autoimmune hemolytic anemias like that which are included like procainamide, levodopa, mefenamic acid, diclofenac. So this is the mechanism that which is involved in the NIPA. Now coming to the signs and symptoms, the drug-induced type of hemolytic anemia patients can present the signs like intravascular or extravascular hemolysis. So intravascular hemolysis means within the circulation lysis. They may result from trauma or by the complement fixation to the RBCs or by any kind of toxic factors. Extravascular means it will be referring as the ingestion of the RBCs by macrophages, that which occurs in the spleen and in the liver. So this is a process that which actually requires the presence of the surface abnormalities on the RBCs like bound type of immunoglobulin conditions. And the onset or the beginning of this drug-induced hemolytic anemia, it is actually variable and it depends on the drug and the mechanism of the hemolysis. And coming to the symptoms of hemolytic anemia, it will be including fatigue, pallor, malaise and shortness of breath. So these are some of the symptoms like because of shortness of breath and malaise and fatigue, so pallor type of conditions. So coming to the symptoms like symptoms of the anemia are like red in the severe anemia, means the eyes will be mostly in red color in the severe anemia. Central symptoms like fatigue, dizziness, fainting, and in the blood vessels like low blood pressure, skin like paleness, coldness, shortness of breath, weakness, changed stool color, spleen will enlarge. In heart, palpitations, chest pain, angina, and low blood pressure can also be seen. Now coming to the diagnosis, as I have said in the previous test, there will be a test that is direct Coombs test. So direct Coombs test can also be said as DAT or the direct antiglobulin test. So this test will be identifying the foreign immunoglobulins either in the patient's serum or on the RBCs. So it is a best mean to diagnose drug-induced immune hemolytic anemia. If it is positive for IgG or complement on cell surfaces, agglutination will form. And there is also an indirect Coombs test. It will identify antibodies in the patient's serum. So this test is actually performed by combining the patient's serum with a normal RBC. Then it will be subjected to the direct Coombs test. Antibodies that have attached to the normal RBCs will get identified. So this procedure, it is also very important in the blood bank procedures, as regarding the storage of the blood is one of the main feature. So it is also important in the blood bank procedures. This is the direct Coombs test versus indirect Coombs test. So as we can see in the direct Coombs test, here the antigen and erythrocyte in vivo antibody coatings is occurred, and so here these are known. whereas these are the anti-IgG reagent. If it is added after the erythrocytes are washed, then this IgG coating will be occurred to the erythrocytes, whereas in the indirect means antibodies in the serum are detected. So this is the difference between direct and indirect. Now coming here to the treatment, the severity of the drug-induced immune hemolytic anemia, it will be depending upon the rate of destruction process, like that is the hemolysis, destruction of the RBCs process. So here hemolytic anemia, that which is caused by the drugs through Hampton mechanism or adsorption type of autoimmune mechanism, their onset means their treatment onset will be slower, in onset, and to also their symptoms onset will be slower and they will be in a severity range of mild to moderate severity. And coming to the hemolysis, that which is prompted or caused through the neoantigen mechanism, that is the innocent bystander phenomenon, they are also having a sudden type of onset. Means this may lead to such type of severe hemolysis and it can also lead to the renal failure. So for such type of conditions, the drug-induced hemolytic anemia, that to immune hemolytic anemia, it will be including the first and foremost step in any kind of drug-induced conditions. First of all, the confirmation, then the removal of such type of problematic or offending agent, then supportive care. In the severe cases, glucocorticoids will be helpful, and the other agents like the drugs like chimeric anti-CD20 monoclonal antibody and other types like rituximab. So chimeric anti-CD20 monoclonal antibody, that is rituximab, and immunoglobulin treatments, these can also be useful. So this is the treatment regarding the drug-induced immune hemolytic anemia. And thank you so much for listening to my presentation, and if you like my video, like, share and please comment to my videos so that I'll clear your doubts regarding the videos. And please subscribe to my channel and forward my channel, and please support me, and thank you.